Hello, everyone. I am Dr. Ariel Gregorio Tolentino, founder and course director for Tolentino NP Reviews. Welcome to our webinar on chronic obstructive pulmonary disease, or COPD. We will be discussing the following items: the introduction to this condition, the medical history, the physical assessment, diagnosis, particularly the criteria involved in this according to the GOLD guidelines, differential diagnosis, the use of spirometry, categories for severity, the CAT assessment tool, and the MMRC assessment tool. We will also be discussing the very important ABE assessment tool. This replaced the ABCD in 2023. We will also be discussing management guidelines for the initial treatment and follow-up treatment. We have a list of key points, very important for those taking the board exam for nurse practitioners, and clinical vignettes to wrap up and to check the knowledge that we have obtained from this webinar. This is part of our educational series that will be very helpful for primary care clinicians, particularly those nurse practitioners preparing for the board exams. This will clarify important features of the new GOLD guidelines for COPD. Very important also for the clinicians in school, those in training, or those in actual practice. Tolentino NP Reviews has helped thousands of nurse practitioners pass the boards, and this lecture series has high yield, must-know content to help the nurse practitioner to do well in the exam and in clinical practice. I'd also want to mention that Tolentino NP Reviews is partnered with the League of Volunteers for Relief Expeditions, or LOVE. This is an organization I founded, and it's dedicated to conducting medical missions in areas of need and disaster-stricken regions. Part of the proceeds from Tolentino NP Reviews goes to this humanitarian cause. Now, before we start the introduction, I just want to mention that this webinar contains clips for your breath sounds and video clips so you could see patient scenarios. So I would encourage you to please put on your high fidelity speakers. And I will also be using my laser pointer to go through or navigate different protocols. So please, it would be nice to view this on a large screen so you could easily follow the laser pointer as I navigate through the different flow charts and your protocols. With the introduction, let's have epidemiology of this condition. I mean that COPD is a common and serious disease condition affecting nearly 16 million people in the United States. This is the sixth leading cause of death, and it carries heavy disease burden, and patients and the healthcare systems are really burdened by this condition. But with proper early diagnosis and treatment and intervention, COPD may be managed effectively. Okay. In this webinar, we are covering the GOLD initiative for chronic obstructive lung disease protocols. Okay, so GOLD provides globally recognized guidelines for assessing, diagnosing, and managing COPD. Yearly updates are made, and vital information are based from rigorous research and the most current evidence-based recommendations. The GOLD guidelines define COPD as a heterogeneous condition, meaning to say there's multifactorial causality and multiple factors contribute to its disease progression. COPD is always a chronic respiratory, with chronic respiratory manifestations. There's a presence of airway abnormalities. It is persistent, and it is a progressive airway obstruction problem. Okay. Now, with regards to the different classifications or naming standards, these are based on etiotypes or the different etiologies causing COPD. We have COPDG. Now, COPDG refers to the genetic influence on the development of COPD. With this nomenclature, it's very important to note the alpha-1 antitrypsin deficiency. And we know that alpha-1 antitrypsin is normally needed to protect the alveoli from the proteolytic damage. So with the deficiency of this alpha-1 antitrypsin, we would have widespread damage of the alveoli. Of course, due to this disease condition, GOLD recommends screening of all COPD patients with alpha-1 antitrypsin deficiency. They have to be screened for that condition. This condition manifests early in life, 25 to about 50 years old, manifesting with COPD manifestations. They affect the lungs, causing emphysema, affecting the liver, causing inflammation, fibrosis, and cirrhosis. Okay. We also have COPD-D. Now, COPD-D is associated with the developmental problems in the pediatric age group. It is associated with premature birth and low birth weight. COPD-C, Charlie, is associated with tobacco smoking. And we know that smoking is the most important modifiable risk factor in the development of COPD. We also have COPD-P, and COPD-P is related to the exposure to pollutants, the burning of biomass, the exposure of humans to suspended particles or fumes in the workplace. We also have COPD-I. COPD-I is related to infections, and very important to consider would be tuberculosis, HIV-associated COPD, and recurrent childhood infections. We also have COPD-A alpha, and this refers to COPD with asthma. Now, other conditions wherein the etiology or the reason for developing COPD is unclear would be classified as COPD-U, being undetermined. Okay. Now, we now have here the current concept of the development of COPD based on FEV1 trajectories. FEV1 is your forced expiratory volume in the first second, and it highly correlates with the lung function. And these trajectories are based on the complex interactions of genes and environmental exposure to those risk factors I mentioned in the environment, also intrinsic problems like the genetic makeup of an individual affecting the decline of FEV1. Now, in this graph, we see here the x-axis being represented in age in years, and the y-axis being represented by lung function. We see here at birth to about 20 to 25 years of age, there is a steep incline or a very quick improvement in the lung function of individuals. And this is followed by a short plateau, and then is followed by a gradual decline as the lung matures or ages. Now, during the pediatric age group, these patients in that population may succumb or be affected by infections, congenital problems, or developmental anomalies. And in some situations, part of that population will be able to have compensatory mechanisms to catch up and regain that opportunity or ability to develop good lung function. But some would have growth failure and succumb to premature death. And of course, these trajectories also would paint the scenario wherein early COPD may develop due to those confounding factors. Now, let's talk about the pathophysiology involved in COPD, more so related to the two most common subtypes, which is chronic bronchitis and emphysema. Now, with chronic bronchitis, it's very important to know the definition, and this is associated with chronic cough productive of sputum for at least 3 months in a year for 2 consecutive years. This is marked by your significant airway inflammation, causing your airway, the walls of the airway to be thickened, causing your lumen to be narrowed. And in addition to that, there is a production of copious sputum, further contributing to the narrowing of the air passages, and this causes air trapping. On the other hand, we have emphysema. And in emphysema, there's destruction of the gas exchange structures in the lungs. Those minute alveoli are damaged, and parenchymal destruction correlate with decreased elastic lung recoil and the decrease in the ability to maintain an open airway on expiration, hence causing air trapping. So collectively, between these two disease entities, chronic bronchitis and emphysema, you have a limitation in lung emptying on expiration, hence air trapping. This causes your decreased FEV1, decreased forced expiratory volume in the first second, and we will examine the details of that. It also causes decreased FEV1 over FVC ratio. FVC is your forced vital capacity. And this also causes your increased exertional dyspnea. And this leads to your decreased lung function. Now, with the histologic picture, we see here the normal alveoli with intact alveolar walls. Now, if these are exposed to your proteolytic enzymes, there would be widespread destruction of the alveolar walls, and you see a lot of succulations filled with air. But then this decreases the surface area, which is very effective for gas exchange. Hence, there would be lower oxygen saturations in this PEEP. Now, we now go to the medical history. When obtaining the medical history, we have to ask about the features of dyspnea. Is dyspnea progressive over time? Is it worse with exercise? Is it persistent? Do we find a recurrent wheeze? Of course, this is associated with your airway narrowing. Usually, patients would have a chronic cough with sputum production, and the sputum might be copious or just scant or none at all. There would be exposure to recurrent respiratory tract infections, and we should always remember to ask about the risk factors, particularly tobacco smoke. Smoking, again, as I mentioned, is the most important modifiable risk factor in the development of COPD. Check also the possible exposure to burning biomass, these cooking fuels. And again, as I mentioned, the exposure to environmental pollutants, particularly in the workplace. Host factors, again, very important to emphasize, the genetic predisposition, the developmental abnormalities in the pediatric age group, including the effects of low birth weight, prematurity, and recurrent lower respiratory tract infection in the pediatric age group. Now we go to the physical assessment findings. Again, comparing these two main subcategories, chronic bronchitis and emphysema. With chronic bronchitis, you see the habitus being an obese person, high BMI, with chronic productive cough. We see here this image expectorating yellowish sputum. There would be prolonged expiration due to air trapping, decreased breath sounds due to hyperinflation, and these persons would be cyanotic. Hence, these people are called the blue bloaters. And you may have peripheral edema due to pulmonary hypertension. The case with emphysema would present another way. The habitus would be cachectic. They would have ectomorphic features. The patients would be barrel-chested with increased antero-posterior diameter. There would be decreased breath sounds due to hyperinflation, minimal cough, tachypnea, and pursed lip breathing. Now, this pursed lip breathing is a compensatory mechanism that we will demonstrate later on to improve ventilation. These people have pink skin, so they are called the pink coughers. Again, on the right upper quadrant of the screen, we see the pathophysiology of those two disease entities, with chronic bronchitis showing inflammation of the airways, causing thickening of the airway walls, narrowing of the lumen, and production of copious mucus. And in emphysema, this is characterized by the destruction of alveolar walls, and you could see those succulations on the gross morphology of the lung compared to the healthy lung. Okay? Further physical exam findings. I have prepared a table for you, which shows the different procedures, the different tests. They are various auscultatory tests or tests for palpatory tests or percussion tests. We have the names of the tests on the left most column, the procedure on the next column, and the following columns would define the results for a hyperinflated lung in COPD and the consolidated lung, which you may see in pneumonia. You may see in atelectasis, fluid in the lungs like empyema thoracis. You may also see this in situations where there is a lesion, a malignant space-occupying lesion in the lungs, which may actually deflect midline structures to the contralateral side. Now, let's discuss this systematically. Let's start with egophony. With egophony, this is an auscultatory test wherein the patient is instructed to say E. Okay. Now, this E sound on your auscultation will be heard also as an E quality of a sound if the patient has hyperinflated lungs. Okay. Now, if the lungs have consolidation, meaning to say density of the lung parenchyma, there would be a bleating quality of E. So E will be heard as an A. E becoming an A on auscultation. That means to say that there is consolidation compatible with pneumonia, atelectasis, fluid, and a mass in the lungs. For bronchophony, this is also an auscultatory condition. Auscultatory test wherein the patient is asked to say 99. And in the hyperinflated lung, 99 will be heard as if it's muffled, and the result would be decreased bronchophony. In the consolidated lung, 99 would be heard louder and more distinct. Now, the concept of this quality of sound on auscultation being heard louder on the consolidated lung is that a more dense parenchyma is able to transmit sound or vibration even better than air. Okay, so that's the concept behind that. For whispered pectoralicoid, this auscultatory test requires the patient to whisper 99. Now, on the hyperinflated COPD lung, you have your faint auscultation of the whispered 99, and that would be a result of decreased whispered pectoralicoid. Okay. Now, for 99 being heard on your stethoscope on auscultation for the consolidated lung, 99 will sound louder and more distinct. Now, for tactile fremitus, this is a palpatory test wherein the patient speaks 99 and the clinician evaluates the vibrations on the chest wall using the hands, the bony prominence on the hands. There would be decreased vibration or decreased tactile fremitus on a hyperinflated lung, and the consolidated lung would have high or increased vibrations and increased tactile fremitus. Now, for percussion, this would require the clinician to place his hand on the chest wall, and the pleximeter, which rests on the chest wall, will be struck by the flexor finger striking the pleximeter. And if there is hyper resonance to percussion, that is consistent with hyperinflated lungs, and it would be dull to percussion if there is your consolidated lungs. Okay. Now, on the right, we have a listing of further evaluation findings. And of course, most of those findings here in the matrix are consistent with your pulmonary hyperinflation or trapping of the lungs. Okay? Air trapping in the lungs cause that. Now, you have the evident, you will be able to see significant use of your accessory muscles of respiration. And that would be your trapezius, your scalenus, your sternocleidomastoid intercostal muscles. And we have a film clip that will show you the mechanisms of respiration to show you how these muscles move, and also clips of actual patient scenarios where you would see the accessory muscles of respiration being used. The patient may also exhibit pursed lip breathing, and pursed lip breathing is the exhalation via a pursed lip. And this increases the positive expiratory pressure in the airway. This decreases airway collapse and decreases airway resistance. Hence, this decreases the residual volume and increases ventilation. So that's a good compensatory mechanism to breathe better in COPD. You may even see the Hoover sign. This is the inspiratory indrawing of the lateral rib cage. We may be able to see the recession of the supraclavicular fossa. This is the concavity superior or above your bony prominence, the clavicle. You could also see retraction of the intercostal spaces. And this retraction of these spaces is due to the expansion of the thoracic cage. Patient may exhibit the tripod sign, and this optimizes the movement of accessory muscles, those muscles in the shoulders, the neck, and the chest, to assist in the weakened diaphragm when inhaling and expiring. And that improves ventilation. Okay. We may also see respiratory alternance, and this is the alternating use of chest wall muscles and abdominal muscles for respiration. And this is very commonly seen when there's impending respiratory fatigue. You can also see tracheal descent on inspiration. This cartilaginous prominence on the trachea will be descending on inspiration. We have a clip on that, and you will be able to visualize this tracheal descent. There's, of course, decreased intensity of breath sounds, crackles, and wheezes on your auscultatory findings. Now, this is an interesting slide which shows us several breath sounds, which is very common. Fine crackles, coarse crackles, and wheezing. Again, if you have your high fidelity speakers, put them on to be able to listen and appreciate the breath sounds. First, we have fine crackles, and we usually compare this with coarse crackles, okay? Fine and coarse crackles, they're both non-musical. They're caused by passage of air through fluid. Of course, in the lungs, the fluid would be mucus. Now, in fine crackles, this is due to rapid air entry or rapid collapse of small sections of the lungs, those alveoli. They are higher in pitch compared to coarse crackles and common at the end of inspiration. And of course, because of its location at the end of inspiration, it's of shorter duration. So let's appreciate the sound of fine crackles, okay? Okay, so that's good. That's fine crackles, shorter duration, common at the end of inspiration. Now let's go to coarse crackles. Now to compare to fine crackles, it's also non-musical. But then the passage of air would be through mucus in the larger airway, like the bronchi. Okay, is relatively lower in pitch and heard in both inspiration and expiration. And because of that, it is due to you'll find it with a longer duration compared to fine crackles. Okay, so let's listen to this. So we noted the longer duration of your coarse crackles because it's found in both inspiration and expiration. Okay. Now we have wheezing. Now wheezing is a musical type of a breath sound. It could be musical polyphonic or monophonic, and it could be high or low. Now, this wheezing, of course, is due to the velocity of air that is passing through those narrowed airways. And of course, the caliber of those airways could be narrowed due to different reasons. It could be due to mucus, or it could be due to lumen constriction, due to inflammation, or bronchoconstriction. And this breath sound is common in the expiratory phase. Okay, so let's evaluate this wheezing. Okay, so we heard the musical sound in wheezing, very common on expiratory phase. Okay, so let's go to the next slide. The next slide shows us the mechanism of respiration. Now, here we will see the different structures that contribute to effective respiration. And of course, that would be your different muscles. You have the intercostalis muscles, you have the sternocleidomastoid, which actually which is the superior aspect of your sternum. It can also originate from the your clavicle. It originates from your clavicle, and you also see your scalenus muscles on this area, which is actually very prominent in the supraclavicular aspect of the neck. Now, it's also important to see this dome-like muscular structure, which is the diaphragm, which helps in respiration. Now, we see also the movement of the rib cage. In the movement of the rib cage, you see this bucket handle movement. So this is likened to the here, increasing circumferential diameter as the patient inhales, and of course, it decreases as the patient exhales. Now, when viewing the rib cage on the lateral aspect, You could also see your anterior posterior diameter could be increased due to the sternal area being pushed forward. Okay. Now, this sternal area being pushed forward is due to the pump handle movement. Okay. And this causes your anterior posterior diameter to increase. Okay. So let's continue the clip. Now, very important to note also is your presence of the dome-like structure, which is, of course, your diaphragm. Now, on expiration, it is very important to note that on expiration, you have your lungs collapsing because air is being exhaled into the environment. And of course, your diaphragm will be more dome-shaped. It will be more elevated, okay? And as the patient inhales, you would have your diaphragm being pushed down on inhalation. Okay, on inhalation, the diaphragm is pushed down inferiorly as your lungs are expanding. So in the phase of inspiration, your lungs are filled with air. It pushes your diaphragm inferiorly. You now have a flatter diaphragm, more flat. So this is very important when evaluating your X-ray findings and also seeing your clinics, your patients in the clinics, and you will be able to see and really correlate the clinical manifestations with your mechanisms of respiration. Okay. Let's go to the next slide now. Now we go to patient scenarios. In this slide, we have here the intercostal retractions, which are very evident on the inferior aspect of the thoracic cavity. You see in drawing of the lateral rib cage, okay? And you see the bucket handle movement, increasing the circumferential diameter of your rib cage, okay? Now, with the next clip, you see the pump handle movement, okay? Pump handle movement, which accentuates your barrel chest conformity of your rib cage. You also see the very prominent supraclavicular fossa, that concavity superior to the clavicle, and also your sternocleidomastoid is very prominent. You see also your trapezius and your scalenus muscles on this area. Now, as we see a lateral view of the patient, you will be able to see the barrel-chested configuration of the thoracic wall with your anterior posterior diameter that has been increased. Okay. Now we see the structures on the neck. You see your sternocleidomastoid again with those origins from the manubrium and the clavicle. You see the scalenus muscles on this area on the base of your supraclavicular fossa, and also your trapezius muscles on the back. You also see the tracheal descent on inspiration. Your laryngeal prominence descends on inspiration. So that is what we would like to show you, laryngeal prominence descending on inspiration. We have the posterior aspect of the neck, and you see more of the work of your trapezius muscles. And because your trapezius muscles are made to stabilize and move the scapula, and it helps in expanding the thoracic cage to increase the breathing capacity. You also see some head bobbing in this patient who has shortness of breath. The next slide shows us the posterior area of the thorax. And you see here more of the thoracic area, the thoracic muscles with the trapezius muscles contracting, intercostal muscle retraction. And the patient is assuming a tripod sign. Okay, this tripod sign actually promotes better lung expansion. It is more effective. It promotes a more effective use of your accessory muscles. And it also improves this 3-point stability, very important for patients who are really very weak with respiratory fatigue. Okay. Next would be your criteria now for diagnosis. Very important for diagnosing COPD. We have to inquire about your quality of breathing based on dyspnea, your cough with or without sputum production, exposure to risk factors, both extrinsic and intrinsic risk factors. Now, what is important is the spirometry reading. We have a mandatory value that will help us diagnose COPD. And that mandatory value is your post-bronchodilator FEV1 over FVC ratio, which should be less than 0.7, or if expressed in a percentage, would be less than 70%. Okay. Now, this FEV1 over FVC ratio, of course, is measured by your forced spirometry procedure. It utilizes your spirometer. You see this handheld device on the screen. And an important factor is the proper sealing of the mouthpiece onto the lips of the patient. And of course, there's the effective use of the nose clip to prevent leakage of air through the nasal passages. Your recording device gets the signals from the spirometer, and a printout is produced on this spirogram. Okay, let's have the next slide here. Very important also is the interpretation of your X-ray, your radiologic findings. On the slide, we have a PA view, posterior anterior view, and also your lateral view for both normal and abnormal patients having COPD. Now, important to note, your increased radiolucency, those dark areas on both lung fields, they are indicative of air trapping. There's a lot of air in the lungs, causing increased radiolucency. There would be flattening of the diaphragm. As we remember in our animation for your respiratory mechanics, as your air in the lungs increase, it would push your diaphragm inferiorly, causing this diaphragm to be flattened. And you could compare to the convexity of the diaphragm in the normal X-ray. Okay. You also have pruning of the peripheral vasculature. So your peripheral vasculature, those vascular markings as they emanate from the hilar area would be decreased. You could hardly see them on the COPD lung due to air trapping. There's also increased retrosternal space, causing the anterior posterior diameter to increase. This is very evident on the lateral view. As you can see here on the bottom, lateral view of a patient with COPD, you see that this is the sternum, and the retrosternal space has been increased compared to the sternal area with a very narrow retrosternal space, in effect, causing an increase in your anterior posterior diameter for the patient with COPD. Widening of intercostal spaces, clearly seen here on this aspect. And of course, the widening of those intercostal spaces are due to the pooling of the muscles that are in the rib cage, because they have to accommodate the contents of air in an expanding lung. Okay. You also have the narrowed and more vertical cardiac silhouette. So your cardiac silhouette delineates the appearance of your heart. And if this cardiac silhouette is viewed in a patient who has COPD with extensive air trapping, we have marked narrowing or a cylindrical conformation of this cardiac silhouette. Now, if we are actually dropping an imaginary line, the mid-clavicular line, from half of that clavicle, that mid-clavicular line, hypothetically, line should intersect with the anterior aspects of the 5th, 6th, and 7th rib in a normal chest X-ray. And also it intersects with the superior area of your diaphragm. But now if that area of intersection is pushed inferiorly, that is an indication of a hyperinflated lung in your COPD case. Now, knowing the diagnosis, we have to differentiate other disease entities that may be confused with COPD. Of course, we have the asthma, because we also have extensive air trapping in asthma, particularly status asthmaticus. But in asthma, we are able to see the atopic triad when you're doing your history taking. The atopic triad is commonly noted with, of course, your asthma. You have your allergic rhinitis and dermatological conditions like your atopic dermatitis and or eczema. Okay, so you would see that on your history. You may be able to elicit the involvement of known triggers, such as this pollen suspended in air or during springtime, or the exposure of a person to dust particles or noxious fumes in the work environment, triggering asthma. Now, when doing a spirometry, you will be able to demonstrate variability or reversibility of airflow limitation. Your FEV1 will be noted to improve by as much as greater than 12% and greater than 200 ml post-bronchodilator challenge. So we mean by that is the post-bronchodilator challenge is the giving of like a short-acting beta agonist like albuterol, and then performing again your FEV1 over FVC ratio, and it would show an improvement because asthma would, of course, improve with the introduction of your short-acting beta agonist or long-acting beta agonist, but there would be no favorable response in COPD due to the destruction of the lungs after several years, several decades of exposure to pollutants. Okay, for heart failure, we would always find a significant cardiac history, probably the history of an MI or cardiomyopathy leading to heart failure. Of course, physical exam findings, you would find manifestations of either left or right-sided heart failure, or both. The physical exam and the X-ray radiologic findings, you might find cardiomegaly or a decreased ejection fraction or even elevated brain natriuretic peptide. Now, your brain natriuretic peptide, this substance is actually produced into and released to the peripheral circulation if you have your stretching of your ventricles, which are always and commonly associated with congestive heart failure. We have bronchiectasis. Bronchiectasis causes air trapping also, and there would be chronic cough productive of very copious, very purulent sputum, even more voluminous compared to your chronic bronchitis. There would be recurrent lung infections, and this is secondary to stasis of your sputum, and this is a needless for infection. Your chest X-ray would show dilated bronchi and honeycombing, which is pathognomonic for the bronchiectasis. In tuberculosis, of course, you'll be expecting a chronic cough with this. May have hemoptysis, bleeding, blood tinged sputum. Your PPD result would be positive for that induration, and your Mycobacterium tuberculosis would be positive for culturing, and of course that would be your confirmatory finding for that. Patients, the patient demographics would usually point out to patients coming from or living in congregate living facilities like nursing homes or the prison, or they could be immigrants from endemic areas of the world. Chest X-ray findings may show apical infiltrates. Now, we may have these apical infiltrates because we know that Mycobacterium tuberculosis is an obligate aerobe, and they would be surviving in areas with high oxygen tension. And these areas in the lungs would usually be the apices. So we have a lot of infiltrates on the top parts of the lungs. In severe cases in pulmonary tuberculosis, you will be able to see cavitation. In bronchiolitis, we also have air trapping, but this is easier to rule out because this is commonly found in the pediatric age group. And your respiratory syncytial virus is the most common pathogen. You will see the manifestation of bronchial inflammation, increased mucus causing air trapping, coryza, respiratory distress. But this condition would resolve sooner, resolves in about 2 to 3 weeks, self-limiting. Now, we go to a very, very, very important chart. And this chart is the GOLD ABE assessment tool, okay? Now, this tool is very important because it guides us in the diagnosis of COPD. And of course, we read this from left to right, guides us to spirometry readings with the mandatory value, which gives us the diagnosis of COPD. And it guides us to the assessment of airflow obstruction, meaning to say that's the severity of COPD according to GOLD 1 to GOLD 4 grading. And we are able to assess signs and symptoms the symptomatology, okay, symptomatology based on your MMRC and CAT score, which are symptom related instruments that are answered by the patient, and the evaluation of exacerbation history in the previous year, including hospitalization. So, of course, the ultimate goal here is to triangulate and know if we have an A, B, or E grouping of a patient, to be able to know the recommended medication for these patients. So this is the basic flow that we are expected to know using the new ABE assessment tool. Now, because it's very important, and we have to know the exact details of each area on this tool. I made it a point that I am projecting this tool for each of those next slides that will explain the details of each of these smaller boxes within the assessment tool. So I will make it a point that it's projected and well explained all the time, so you know the correlation of how each of these work in the tool to diagnose COPD. Okay, and the first slide related to that is your post-bronchodilator value, which we have discussed earlier. So this value of less than 0.7 or less than 70% FEV1 over FVC ratio is projected to this area, the left lower quadrant of this ABE assessment tool. Now, to give more detail on how we arrive at that ratio, we now examine spirometry readings, comparing A normal tracing, and comparing it to B, an abnormal tracing showing airflow obstruction. Okay. Now, with the normal tracing, we need to know two values: your FVC, your forced vital capacity. Again, that is the amount of air or the volume of air that can be exhaled after full inspiration. It has an assigned value of 5 in this example. So that would be 5 liters. And the FEV1 is your forced expiratory volume, and it has a assigned value of 4. Okay. So as you can see here, defining the specific areas of the graph, your y-axis would be the volume in liters, and the x-axis would be the time it takes to exhale a certain volume of air. Okay, so this 4 over 5 would give you a 0.8. Now, when you get a result for your spirometry readings, you compare it with the known threshold of less than 0.7. So clearly, it is greater than 0.7. Hence, 0.8 is associated with a normal tracing for a normal individual, no airflow obstruction. Okay. Now let's go to B, tracing B. Tracing B is for a patient with airflow obstruction. Take note that there is a decrease in FVC, forced vital capacity, but then there is even a marked or more significant decrease in FEV1 compared to your normal individual. See? So there is a assigned value for FVC of 3.2 liters, and your FEV1 is 1.8 liters. And doing the ratio, you get a result of 0.56. And of course, 0.556 is less than 0.7. So that gives you an indication this is an obstructive problem. It is a spirometry reading for a person with airflow obstruction. Okay, so that is how we are able to compare and contrast the results of spirometry readings in relation to the threshold value to determine whether the patient has airflow obstruction compatible or not compatible with COPD. Okay. Now, next one. We are now dealing with this box on the center, almost on the center of the GOLD AB assessment tool. This is concerned with determining the severity of COPD. Now, take note that this FEV1, the basis is your post-bronchodilator FEV1. So this is after a bronchodilator has been introduced to the or given to the patient, like a short-acting beta agonist, like albuterol. If your FEV1 is greater than 80%, that would be mild or GOLD 1. GOLD 2 or moderate would be an FEV1 less than 80%, but greater than 50%. GOLD 3 or severe would be an FEV1 of less than 50% or greater than 30%. And GOLD 4 would be very severe, that would be an FEV1 of less than 30%. Okay. So now, when FEV1 is being checked using the procedure of spirometry, as I mentioned earlier, the patient is asked to give a forceful blow onto the spirometer. So, and the device will actually determine the volume of air that is being exhaled in the first second. So I have prepared here a video to show you how this is done. And take note, on the background, you would hear the coaching of your respiratory therapist to coach and guide the person on the proper procedure to do. As you can see, forceful breathing out of air, and the device, the spirometer, will be able to capture the volume of air forcefully exhaled in the first second. And those are the values that are being used to determine the severity of COPD. Okay, so let's have the next slide here. Now, with the next slide, we are now evaluating symptomatology. These are symptomatology or symptom tools. These are questionnaires that are accomplished by the patient. Okay, there are two tests that we will discuss. The first one is the CAT assessment tool. This is the COPD assessment test. Okay, and the CAT assessment is actually projected onto this Gold AB assessment tool. It's located on the right lower quadrant. And you can see here a CAT of greater than equal to 10 will give you an A, and a CAT of less than 10 will give you, it will give you a B, and CAT of greater than 10 will give you a B. Now, related to this CAT assessment tool, we have a total of 8 determinants. These 8 determinants, which is projected on the left side, these are associated with good physical condition. And those same determinants, worded differently, are associated with worse physical conditions. So let's give you an example of how this works. If, for example, a patient never coughs, so it says here, I never cough. If the patient doesn't cough, then with a Likert scale scoring of 0 to 5, the score would be a 0. If the patient coughs all the time, so on the extreme right side, indicating a worse physical condition, the patient coughs all the time, then the patient would score that a 5. So if the patient is coughing just a little bit, then he could score that a 1. So this would give you the symptomatology result, okay? Now, those determinants, those 8 determinants are, according to the first one, cough frequency. The second is the presence of mucus in the chest. The third one would be chest tightness. The fourth one would be being breathless when walking up a hill or a flight of stairs. The fifth one would be limitations in home activities. The sixth one would be confidence of leaving the home due to this lung condition. And the next one, the seventh one, would be sleep quality. And the last one, the eighth, would be energy levels. So those are the determinants. And of course, if we have 8 determinants and scoring of 0 to 5, the maximum score would be 40. And again, that defining score to separate A from B would be a CAT score of 10. That's very important, a CAT score of 10. And we will be going into more detail about how those CAT scores are used to actually triangulate an A, B, and E grouping. Okay, let's go to the next symptom scoring tool. And this is called the modified MRC Dyspnea scale. MRC is your Medical Research Council Dyspnea scale. This is a simpler tool with only 0 to 4 scoring. Okay, and the patient is just asked to mark one box and mark the box with those determinants that closely resemble the patient's symptoms. Now, for grade, that would be only being breathless with strenuous exercise. Grade 1 would be having a shortness of breath when hurrying on the level and walking on an incline. Grade 2 would be walking slower than a person's same age as the patient due to breathlessness or the need to stop for breathing when walking at the patient's own pace. Okay. Grade 3 would be requiring to stop after walking 100 meters to take a breath, or after walking a few minutes on the level, requiring to stop to take a breath. And the last grouping would be being too breathless to leave the house, or being breathless just by dressing up or undressing. So those are the different determinants for your modified MRC dyspnea scale. And again, that is projected on the lower right quadrant. And as we see here, the grading of 0 to 1 coincides with an A, and a grading of greater than or equal to 2 would be a B. Okay? Now, we are back to the ABE assessment tool. And we are now ready to triangulate the A, B, and B groupings. And this is based on your exacerbation history. As you can see here, you have two boxes, the exacerbation history. So it's very important to follow the laser pointer, so you know how we are navigating through the ABE assessment tool. On these boxes, you see the exacerbation history. On the top box, that would be 2 or more moderate exacerbation history in the previous year, or 1 or more leading to hospitalization. Okay. And on the box below, you have 0 to 1 moderate exacerbations, and none of those exacerbations leading to hospitalization. Now, we know that it is an A if this box below, which says 0 to 1 moderate exacerbations and none of those exacerbations leading to hospitalization, is coupled with any of these symptomatology scores from those instruments. If it is coupled with an MMRC of 0 to 1 or a CAT score of less than 10, then that would point to an A category or A grouping. And if that is coupled, this exacerbation history and hospitalization history is coupled with an MMRC of greater than or equal to 2, or a CAT score of greater than or equal to 10, then that would be a B grouping category. Okay. Now, the E grouping category is solely dependent on your exacerbation history and hospitalization. If the patient has a greater than or equal to 2 moderate exacerbations in the previous year, or any of those hospitalizations, any of those moderate exacerbations have hospitalizations of even 1 or more hospitalizations resulted in the previous year, that would be an E. Okay. Now, take note, any of these symptomatologies grouping or scoring are not really relevant for the diagnosis of, or giving an impression of, a group E for the COPD grouping, which would, of course, lead you to the pharmacological intervention. So always remember that in the grouping of E, what is important is the exacerbation and hospitalization history. Okay. Now we know that we have triangulated A, B, and E. It is now time to address or assign important pharmacological interventions for these groupings. Now, this is projected. This pharmacological treatment, which is the initial pharmacological treatment, is projected onto this area of your ABE assessment tool. Okay, so it is very clear that this is what we are talking about, the ABE grouping. Now we're looking at the pharmacological interventions. For group A, we could, of course, use a bronchodilator. We could even give an example like a short-acting beta agonist, like an albuterol or levobuterol. You can also give a long-acting beta agonist in the form of formoterol or salmeterol, because those are examples of bronchodilators. Now, for group B, we should give a LABA plus a LAMA, this dual combination therapy. And of course, your LABA is formoterol or salmeterol. You have to add a long-acting muscarinic antagonist, a LAMA. A common LAMA is your tiotropium. Okay. This asterisk here tells us that it is better to select, whenever possible, the combination of a LABA and LAMA in a single inhaler, because this is more convenient for the patient and it increases compliance for the administration of this medication. Now, for group E, there are two possibilities. The patient could either have the LABA-LAMA combination, which is also used in group B, or the patient can have a triple combination therapy of LABA, LAMA, and ICS if your eosinophil count is greater than or equal to 300. So we have to factor in the eosinophil count to make that choice with the LABA, LAMA, ICS triple combination. Without that eosinophil count being greater than or equal to 300, the recommended medication for group E would be LABA plus LAMA. Okay. So that is very, very important. Now, with each successive consult and follow-up, the clinician would, of course, be evaluating the patient's response to therapy, and the clinician will be reviewing the symptoms, evaluating dyspnea, evaluating exacerbations, if any, assessing the inhaler technique, the use of your meter dose inhaler or spacer if needed, and adherence to non-pharmacological approaches, including your pulmonary rehabilitation or self-management education. And so because of the response of the patient, the clinician may opt to escalate or de-escalate or switch inhaler devices or switch molecules or switch, that means to say switching molecules would be switching the type of pharmacological regimen being taken by the patient. Okay. Now, if on consult we find that the patient is not responding favorably, we have the option to, of course, we have to check any indicators of failure. The patient may have poor adherence to the inhaler technique. The patient may have other comorbidities that need to be addressed, like pneumonia or heart failure that needs to be addressed separately. Now, if we have to check and evaluate if it is a treatable trait related to dyspnea or exacerbation, we have to know the definitions of each. Dyspnea is associated with shortness of breath with exercise intolerance. Okay, so shortness of breath with exercise intolerance. So the algorithm specific for that is this algorithm below. So in essence, if the patient is on a monotherapy long-acting beta agonist, your LABA, like formoterol, for example, monotherapy, then you just have to add a LAMA because you have to end up with a dual therapy if your monotherapy is not that effective for dyspnea. Now, monotherapy for LAMA, a long-acting muscarinic antagonist like tiotropium, and the response isn't so good. Patient is still having dyspnea, and so you just have to add a LABA, your long-acting beta agonist in the form of, like, say, formoterol or salmeterol. And you have the option also to consider switching inhaler devices or switching the different types of pharmacological regimen to achieve your optimal improvement. Okay. Now, if the patient is suffering from a mixture of dyspnea and exacerbation or just exacerbation, we have an algorithm that we have to follow. But first, we have to distinguish and know what is the definition of exacerbation. So exacerbation is defined as your dyspnea, increasing severity of dyspnea, increasing severity of cough productive of mucus. And this increasing severity of manifestations, your signs and symptoms, are within a period of less than 14 days, less than a period of 14 days. Okay. So when that criteria has been evaluated and we check the medications on board, let's have examples here. If the patient is on a LABA, your long-acting beta agonist, for example, your formoterol or salmeterol for monotherapy, and if the eosinophil count is less than 300, we have to escalate to a dual therapy of LABA plus LAMA. In the same way, if the patient is on a monotherapy for LAMA, the same way, we have to escalate to a dual therapy of LABA plus LAMA, taking note that your eosinophil count should be less than 300, okay? Now, if the person is on a monotherapy of either LABA or LAMA, and the patient is not responding well, having exacerbations, and your eosinophil count is greater than or equal to 300, we have to escalate by adding your ICS and to your combination of LABA and LAMA, you will be ending up having a triple therapy of LABA, LAMA, ICS. Okay, take note about that determinant for your eosinophil count. Now, if in case the patient has a LABA, LAMA, ICS triple combination, and the patient has pneumonia, and it is not indicated to use ICS, your inhaled corticosteroids, for long periods of time, or if there's an adverse effect to that medication, you can actually de-escalate and remove ICS, de-escalate to just the LABA-LAMA combination. But it's very important to consider, according to the GOLD guidelines, if we are de-escalating and removing ICS in the presence of a eosinophil count that is greater than 300, we have to be very careful, because that situation will still prompt or promote the development of exacerbations. It promotes the development of exacerbations. So be very careful in de-escalating in the presence of a high eosinophil count, above 300. Now, if your LABA-LAMA combination is not working for a certain patient with an eosinophil count of greater than 100, we can escalate your LABA-LAMA combination to add an ICS. Then you will have the triple therapy LABA-LAMA ICS. That is, again, if your eosinophil count is greater than or equal to 100. Okay. Now, in two situations, the first situation, if the patient is on a LABA-LAMA combination, that's first situation, and the blood eosinophil is less than 100, that's one situation, okay? And the second situation is if a patient has a LABA-LAMA ICS triple combination, okay? If the patient has any of those situations and there is still worsening of exacerbation, there are two further options. And number one, that is the addition of your roflumilast. Now, your roflumilast is a phosphodiesterase 4 inhibitor. This is an anti-inflammatory agent. And this is best used or added to those regimen that I was discussing earlier. If the patient has an FEV1 of less than 50%, and if the patient has chronic bronchitis, okay? So if this patient is a chronic bronchitis patient with an FEV1 of less than 50, add roflumilast for any of those two situations I mentioned. The two situations are your patient with a LAMA ICS triple combination, or a patient with a LAMA combination, dual combination, but having an eosinophil count of less than 100. Now, if any of those two situations, two cases, have a history of being a former smoker, then azithromycin, that macrolide, is even a better choice for this person, for this patient who was a former smoker, okay, and not doing well with the foregoing therapy that we mentioned, okay. So now let's go to the next slide. The next slide just gives us an overview, a bird's eye view of the total management cycle for COPD. And of course, this is just a review of what we have discussed overall, starting from the diagnosis, evaluating symptoms and risk factors, okay? And checking for the initial assessment, checking your GOLD 1 to 4 for the severity of COPD, checking your symptomatology from those CAT and MMRC symptom tools that are the instruments for patients to answer, checking your smoking status, checking the eosinophil level, evaluating genetic predisposition, knowing if the patient has alpha-1 antitrypsin deficiency problems, tuberculosis, and others. Now we go to the initial management again, and smoking cessation is evaluated. Very important, your vaccination recommendations. We have to note here that the vaccines recommended by the GOLD guidelines would include influenza, COVID-19, your pneumococcal vaccines, which include PCV20 or PCV15, followed by PTSV23. And they also may take the Tdap if the vaccine was not administered during their adolescent years. The zoster vaccine is also recommended. Recommendation RSV vaccine, your respiratory syncytial virus vaccine, okay? and check the self-management and education interventions on initial management and on your subsequent visits to the clinic. You may review the patient's condition. You may do a repeat CAT score and MMRC, checking for exacerbations, seeing if the smoking we've been successful with the cessation of smoking, and check for exposure to those risk factors and others. Okay. Now, because of this evaluation, when we are reviewing the patient with each visit to the clinic, we are now able to adjust pharmacotherapy or adjust non-pharmacological interventions to arrive at the most ideal situation to control COPD. Okay. Now, we're now towards the end, and we have the important key points. These important key points are very, very relevant for those taking the board exam. These are very high yield topics that are contained in the board exam that you have to know. Take note about your FEV1 over FVC ratio, that mandatory value for COPD. Very important to note about your most important modifiable risk factor that contributes to the development of COPD, which is smoking. And of course, take note about the exposure to other factors like pollution. No alpha-1 antitrypsin deficiency, which is very common and manifesting in the younger age, 20 to 50 years of age. And in the root of the question, you might see this important determinants for you to think that this is indeed a COPD case, like the presence of dyspnea, activity limitation, cough, and the quality of sputum, the exposure to infections, and experiences of exacerbation. Know by heart the ABA assessment tool that we have discussed in detail. Know also the different pharmacological interventions for group A, B, and E, and the influence of eosinophil counts on your use of your triple therapy. Know also that oxygen supplementation to prolong life is very, very, very beneficial, particularly for the COPD type of patient with severe resting hypoxemia. Very important, very high yield concept. Your COPD exacerbation definition is very important. Your worsening of signs and symptoms within a period of less than 14 days. Your exacerbation of a person with a monotherapy of LAMA or LABA on board and stepping it up to a LABA-LAMA combination if your eosinophil count is less than 300. Take note that gastroesophageal reflux disease, your GERD, is associated with increased risk for exacerbations and of course, poorer health outcomes. In the new guidelines 2024, annual low-dose CT scan is recommended for lung cancer screening for COPD due to smoking. So those are very important key points, particularly for the exam takers and also for those in practice. Now, we are in the part of our presentation wherein we will be tying up and evaluating our knowledge, the knowledge that we have obtained in this extensive discussion of COPD. We will have a clinical vignette, this case, and we will have questions and answers. We would have a polling feature, and please feel free to utilize the poll, answer, and submit, and we will evaluate your performance scores. Okay, so let's go ahead with the clinical vignette. We have a new male patient who is 68 years of age, cachectic, very frail looking with ectomorphic features, and a heavy smoker for decades. This patient consulted due to easy fatigability and dyspnea that is progressive. There's persistent and worsening of these manifestations on exertion. He is afebrile, no fever, with a chronic occasional cough productive of scant white sputum. He reported having recurrent respiratory infections in the past 5 years. While being examined, the patient was noted to be leaning forward and breathing through his lips. He is barrel-chested and has significant intercostal retractions with respiration. All lung fields are hyper-resonant to percussion. Now let's look at the next slide, and it will give you an idea of the appearance of the patient. And we will look into the auscultatory findings for the breath sounds. So take note here about the patient's physical features, patient's positioning, as he is, you would see any sign of similar tripod sign, the manner of breathing, and let's start the video. Okay. So take note that manner of breathing is very, very important for answering the vignette. Now we go to the auscultatory findings. Take note of your very distinct breath sounds, and even be keen on checking background breath sounds that will help you answer the clinical vignette. Okay. Okay, since we heard the breath sounds, let's go to the next. We have radiologic findings also. We have the posterior anterior view and the lateral view, upright positioning of the patient. Take note about the degree of lucency on the lung fields, the appearance of the cardiac silhouette, the appearance of your diaphragm, and also the anterior posterior diameter. Take note of that, and the retrosternal space. The patient underwent spirometry, and the spirometry that was performed gave a post-bronchodilator FEV1 over FBC ratio of 55%. A review of the patient's medical records from another provider revealed 3 moderate exacerbations in the previous year, with 2 of those episodes leading to hospitalization. The patient's CAT score, the COPD assessment test, gave a score of a 20. The blood draw for CBC yielded a eosinophil count of 200 cells per microliter. Those are very important values to remember. Let's go to the first question. What is the primary clinical impression for this case? What is the primary clinical impression? So let's have the poll right now. Let's pull up the poll. Okay, please feel free to answer, and we'll give you about 30 seconds. So here you see different pulmonary conditions, COPD, you have a malignancy, you have airway hyperreactive conditions, and pulmonary embolism as options. Okay, so we're giving you a few more seconds. Okay, let's end the poll now. Okay, and we will share your answers with the correct answer. And of course, our correct answer would be COPD. Excellent, excellent. And we have 97% having the correct answer. Excellent. That is extremely good. Very good, very good. Now, with COPD, this is actually the emphysematous type of COPD. And of course, we could exclude pulmonary carcinoma because we do not have the typical presentation of a mass lesion, which you could see on the imaging on the X-ray. No shifting of midline structures to the contralateral side, and none of those structures in the X-ray that would be compatible with a malignant or a pulmonary mass. Okay. Asthma could be ruled out because of the spirometry readings that are not conforming with airway hyperresponsiveness or a reversal in the airway after spirometry. Pulmonary embolism, of course, this is an acute condition, and it is contradicting the chronicity of the timeline of our disease entity. Going further into the details of the rationale, we see in the case we have dyspnea, which is progressive, persistent, and worsens with exertion. The patient had the chronic cough productive of scant whitish sputum. They noted the recurrence of respiratory infections in the recent 5 years. Patient was a heavy smoker. And the physical assessment findings point to a cachectic patient that's very frail looking, with pursed lip breathing. We saw that video with pursed lip breathing, that compensatory mechanism to for better ventilation in the event of COPD. We have the tripod positioning also for better 3-point stability. The patient is barrel-chested with intercostal retractions and hyperresonance was noted. Auscultatory findings are, of course, significant for COPD. Now, with your X-ray, we have flattening of your diaphragm. And as we remember, with the mechanics of respiration, with that animation we viewed earlier, if your lung parenchyma is expanding due to the accommodation of too much air due to air trapping, it will push your diaphragm inferiorly, causing your diaphragm to be flattened. Okay. There is also your increase in anterior posterior diameter because of the increase in your retrosternal space. You see that the cardiac silhouette has been narrowed and is now cylindrical or tubular. Now you see the absence of your vascular markings. There's the pruning of your vascular markings, okay? Increased lucency because of hyper-aerated lungs. So clearly this is your COPD and it will be your emphysematous type. Let's go to the second question. What physical exam findings are associated with this case and what breath sounds are presented? So let's first review or play the breath sounds, the auscultatory findings. Okay, so take note of the prominent breath sounds, and there could be background sounds that will contribute to a good evaluation of your auscultatory findings. Let's have the poll right now. Please pull up the poll. Okay, feel free to answer the poll and of course click submit after answering. Now, would this be A, hyperresonance with vesicular breath sounds? Would that be B, the vertebral positioning of lordosis with fine crackles and wheezing? Would it be C, Charlie, with decreased tactile fremitus, coarse crackles and wheezing? Or would it be D, Delta, with increased tactile fremitus, use of accessory muscles of respiration and fine crackles? So go ahead and please answer. Okay, and let's end the poll, please. Okay, ending the poll and showing the answers. Of course, the answer would be your Charlie, decreased tactile fremitus with coarse crackles and wheezing. Yes, very good, with 45% answering that correctly. Now, let's stop sharing this. Okay, and we will close the box and evaluate further our answer. With the matrix that we have used for the physical assessment findings, we see here that for patients with hyperinflated lungs with COPD, we have the decreased tactile fremitus and hyperresonant to percussion. Okay, the findings would be percussion and decreased tactile fremitus based on our matrix. And again, the concept here is hyperinflated lungs, the transmission of sound would be less, and there would be this quality of hyperresonance similar to banging on a drum. Okay. Further rationale would point out to the use of accessory muscles of respiration, and of course, you found crackles and wheezing. Now, evaluating the auscultatory sounds, we found both crackles, coarse crackles, and wheezing. And as we again play coarse crackles, just to revisit that as a review. Okay, so you heard coarse crackles, very low pitched, of course, compared to fine crackles. And they are heard in both inspiration and expiration. Hence, you have a longer duration of your coarse crackles compared to fine crackles. Now, with wheezing, this is your musical sound. And let's see that. Now, on the clinical vignette, this was actually of a lower intensity of wheezing, but there was a background wheezing sound on auscultation, and it's very common on the expiratory phase. So the answer there for the breath sounds was a combination of coarse crackles and wheezing. Okay. Now, let's go to the next question. Okay, the third question. What is the gold grouping standard for this patient? Okay, so let's pull up the poll, please. Feel free to answer and click submit when you're done. And would that be a group B, beta? Would it be a group A, alpha? Group C, would it be a group E, echo? Or group C, Charlie? So is it group B, group A, group E, or group C? So take note that your ABE replace your ABCD in 2023. And the reason for that is because your group C isn't very common. It doesn't occur commonly. And your C and D is best combined under E with a larger influence of your exacerbation history and history of hospitalization to arrive at the triangulation of group E as a grouping selection. Okay, so let's end the poll, please. Okay, and our answer would be group E. Group E. Okay, so group E is the answer under, of course, Charlie C. Group E. Okay, let's stop sharing. Okay, and we will close the poll and see the rationale why it is group E. Group E. Okay, now basing this on our assessment tool, our group E should be compatible with greater than or equal to 2 moderate exacerbations in the previous year, or greater than equal to 1 of those exacerbations leading to hospitalization. So that definition is actually congruent with what is presented on the clinical vignette, because in the clinical vignette, there were 3 moderate exacerbations in the previous year and 2 of those exacerbations leading to hospitalization. So definitely that is congruent with the box definition on the top, which is giving you a result of group E on triangulation. Now, the symptomatology score was actually provided using a CAT score, giving a result of 20. Now, it is important to note that the CAT score is not relevant in actually getting that E grouping, because any CAT score would actually you will end up as having an E grouping. So for group E, the most significant influencing factor for the selection of group E would be your moderate exacerbation of being greater than or equal to 2 in the previous year, or your hospitalization of greater than or equal to 1 in the previous year. So that's very important. Okay. Let's go to the fourth question. What treatment regimen should be prescribed for this patient? Okay, what treatment regimen? Let's now pull up the polls again for this fourth question. Okay, and feel free to answer, please. And don't forget to click submit when you have answered. Okay, please answer. Now, would it be a LABA, a long-acting beta agonist, or formoterol plus another bronchodilator? That be still LABA plus a LAMA, a long-acting muscarinic antagonist, which is tiotropium? Or would it be the triple therapy of LABA, LAMA plus an ICS, your inhaled corticosteroid in the form of budesonide? Or would it be a low-dose inhaled corticosteroid plus a LABA? So which one would be the appropriate therapeutic regimen for this question 4? Okay, so let's end the poll, please, and share the correct answer. Of course, our correct answer would be the LABA-LAMA combination, dual therapy, your long-acting beta agonist and long-acting muscarinic antagonist. Okay, so let's stop sharing and explain the rationale for this answer. Okay, so the LABA-LAMA combination as an answer is the answer because we have selected group E, and we are checking another determinant, which is the eosinophil count. Okay, so we know that in group E, there are actually two options that we can use. Yeah, it's either your LABA plus LAMA or the triple therapy LABA, LAMA plus ICS. Now, the triple therapy should be used if your eosinophil count is greater than or equal to 300. But take a look at our eosinophil count in the vignette. It is only 200 cells per microliter. So we should not choose your triple therapy then, and we should choose LABA plus LAMA. Okay, so that is the reason why this is the answer. And of course, the generic name examples for your LABA would be formoterol, and your LAMA would be tiotropium. Okay, so that's very important. The last question: a patient with chronic bronchitis who is on formoterol is experiencing worsening productive cough and dyspnea over past 10 days. Eosinophil count was determined to be 200. What medication adjustment should be done? Okay, so let's pull up the poll, please. Okay, please feel free to answer. Okay, please feel free to answer. And don't forget to click submit to be part of our Q&A. Okay, so just to give a clue here that of course we are using a formoterol as a LABA, initially starting with your monotherapy with formoterol, which is of course your LABA, and so which will be our important next medication for adjustment to use. So let's, is it add tiotropium, add ipratropium, add albuterol, or add tiotropium and budesonide? So let's end the poll, please. Okay, and of course the answer would be to add tiotropium. And of course, tiotropium, let's stop sharing and discuss the rationale. Tiotropium, we know tiotropium is a long-acting muscarinic antagonist. Now, we are choosing that because we have to add that to your formoterol, which is your long-acting beta agonist. And let's see why, okay? Now, clearly, we have to define if the patient is not responding well due to dyspnea, or is it due to exacerbation. Now, in the clinical vignette, we see worsening of cough and shortness of breath and your sputum production within a period of less than 14 days. Okay, so it's less than 14 days. And so if it is less than 14 days with that severity picture, that would be exacerbation. Now, we were presented with a monotherapy from that patient using only a formoterol, which is your long-acting beta agonist. Now, we see here that if your eosinophil count is less than 300, and we know that the eosinophil count in the clinical vignette is indeed less than 300, it's only 200 as your eosinophil count. So what we have to do is add a LAMA. You have to add a LAMA, which is, of course, your tiotropium, your long-acting muscarinic antagonist. You will be ending up with a medication that is with dual therapy, a long-acting beta agonist in the form of your formoterol, and your long-acting muscarinic antagonist in the form of your tiotropium. That's the reason why we have to add tiotropium. And also, again, please consider your eosinophil count. That will help you in your decision-making process, okay? So it's very, very important. We have actually been successful going through all those clinical vignettes and answering successfully. It was a good learning experience. Now we go to the part wherein we will be answering several of those questions that have resulted from the interaction and questions that have been brought to us, which are very important related to this COPD guidelines. Now, while we're discussing the questions, please take note that we have the QR codes here for us to be in contact with you. You may actually join our Facebook group. We have a good learning community there. You may scan this QR code to actually go into the Facebook group. And you may also visit our website and check our products. You may join our live study group or be engaged in the one-to-one products, your readiness test one-to-one and tutorial one-to-one. Okay, so feel free to scan the QR code and visit or be a member of our Facebook group. Now, the first question was about it's requesting a summary of key changes in the GOLD guidelines for 2024. Of course, it's now 2024, and we want to know what are the updates in 2024, and this could be relevant for practice. Now, for the exam, usually it takes a year before your guidelines adapt to the test relevant material. But this is very important in practice. And of course, there would be a time where the number of months would elapse and they would be applying the new 2024 GOLD guidelines. And these are the updates. So there are basically 6 important updates, and they're about PRISM, number 1. Number 2 is about spirometry. The third would be about COPD screening. The fourth would be about the interstitial lung abnormalities. The fifth is smoking cessation. And the sixth would be about vaccination. Now, about PRISM. PRISM means preserved ratio with impaired spirometry. This concept was actually introduced in 2023. But the updates are related to the predictors of your transition to a normal lung or to a lung with obstructive lung disease. So let's take note about PRISM. There is preserved ratio, meaning to say the preservance of the ratio is involved with your FEV1 and FVC ratio being greater than or equal to 0.7 post-bronchodilator. Okay, so take note about that value, greater than or equal to 0.7 post-bronchodilator. But there is impaired spirometry readings of FEV1 of less than 80% post-bronchodilator. Now, the GOLD guidelines in 2024 describes this PRISM as a very unstable phenotype, a very unstable condition, meaning to say it's unstable because it may transition to a normal lung with over time, or it may convert to obstructive lung disease. Now, the important updates are related to the predictors of transition. What are those predictors that we have to evaluate to gauge the probability of transition to normal or to the obstructive lung disease? Number 1 is a lower baseline pulmonary function. Second is, of course, older age and increasing age. Third would be smoking. Fourth would be the female gender. And fifth would be longer expiratory time when doing your spirometry evaluation, particularly on succeeding assessments with spirometry. Okay, so that's important. The second would be the use of spirometry readings. Okay. Now, according to the new GOLD guidelines in 2024, it emphasizes that if your pre-bronchodilator FEV1 over FVC ratio is greater than or equal to 0.7, the clinician doesn't really have to do a post-bronchodilator challenge anymore, except that if the clinician is suspecting that the post-bronchodilator value might be less than 0.7. Okay, that's the only situation that the clinician may do a post-bronchodilator challenge. In the event that your pre-bronchodilator FEV1 over FVC ratio is greater than or equal to 0.7. Okay, the third one is your COPD screening. In 2024, and we included this also in the high yield facts, that your annual low dose CT scan for lung cancer screening for COPD should be done for those COPD cases due to smoking. They have to do the annual low dose CT scan, okay, to eliminate or to screen lung cancer. Fourth is the presence of interstitial lung abnormalities. For example, those lung abnormalities would be pulmonary fibrosis, asbestosis, and silicosis. Now, if there's the presence of these interstitial lung abnormalities, this should raise the suspicion toward the development of COPD, and the clinician should actually evaluate these patients further. Okay, that is a new emphasis on the 2024 guidelines. Regarding smoking cessation, it is emphasized in the new guidelines to actively emphasize the cessation of smoking with each visit of the patient, involving the patient in patient counseling also, and counseling also for the support group, including family members. And of course, given pharmacotherapy or pharmacological interventions when like your varenicline, your nicotine agonist, your nortriptyline, nicotine patch, or your bupropion for smoking cessation. We mentioned on the high yield list the vaccines. And of course, in addition to your flu, COVID, pneumococcal, Tdap, and zoster vaccine, now it is a recommendation to use also your RSV vaccine for those greater than 60 years of age, or those with chronic heart conditions or lung conditions. Okay, so that's those are the important updates for the 2024 guidelines. There was also a question about what is the management for asthma and COPD overlap? Okay, the ACO, the asthma and COPD overlap. So now it's very important to note that currently there is no longer the category for ACO. The asthma with COPD overlap is no longer a category being used. Okay. We are using now the taxonomy for echotypes of COPD-A, if you would remember our echotypes earlier on. And this actually refers to your COPD and asthma to be recognized as two distinct conditions, and they should be treated differently. Okay. Now, if a patient has both asthma and COPD, it's important to follow the asthma treatment and not the COPD treatment. So that's very important. There was also a concern about a request to enumerate the respiratory medications, their mechanisms of actions, and to give examples. So let's go over them again. This is very important to exam takers. Of course, we start with the bronchodilators, very important. Your short-acting beta agonist, an example would be albuterol and levobuterol. We have the longer-acting bronchodilators, your LABA, long-acting beta agonist in the form of formoterol and salmeterol. Now, we have medications that exert anticholinergic activity, and this is your SAMA, your short-acting muscarinic antagonist, which is ipratropium. And the mechanism of action for this is it prevents bronchoconstriction. It also relaxes your smooth muscles in your respiratory tract. And as I mentioned, it has anticholinergic activity, which causes drying up of the secretions. Very important in COPD. Of course, if we have your short-acting muscarinic antagonist, you have your long-acting muscarinic antagonist in the form of tiotropium, a very important, very common medication used for your COPD. And of course, the mechanism of action is the same as your short-acting muscarinic antagonist, preventing bronchoconstriction and relaxing the smooth muscles. And again, anticholinergic activity causing drying up of the secretions. We have also consistently mentioned your inhaled corticosteroid, your ICS, in the form of budesonide. This is, of course, your anti-inflammatory agent. And we have been mentioning, especially on your exacerbation protocol, the use of roflumilast. Roflumilast is a very important anti-inflammatory agent. This is a phosphodiesterase 4 inhibitor that is used in your exacerbation control. We also use the antibiotic azithromycin. This is your macrolide antibiotic. It is known to shorten the recovery time for exacerbations. It decreases the risk of early relapse, but we have to watch out for bacterial resistance, also your bilateral sensory neural hearing loss problems, and also affecting the conduction system, prolonging the QTC interval. So those are important pulmonary medications that we have mentioned during this webinar. Okay. And lastly, there was a concern about the request to elaborate pulmonary rehabilitation. Now, pulmonary rehabilitation is very important in the management of COPD because studies show that there is a corresponding decrease in mortality of COPD patients if pulmonary rehabilitation is initiated early during the time of hospitalization, or if it is initiated within the first 4 weeks after discharge. So that is really very important for the management of COPD to prevent COPD-related mortality. Okay. Now, we have ended the clinical part, and we will now enter the part related to our relationship with the students. So you will be able to avail of our services and be very successful in your board exam preparation and also in practice. So now we have Joanne Ventrella. Joanne is our administrator for Tolentino NP Reviews, and she has a very important message for you. Go ahead, Joanne.
Hi, everybody. Thank you so much for joining us tonight. And for joining Dr. Ariel's very popular COPD webinar. Wasn't that great? I really learned a lot. To find out what else we have to offer for your board exam success, you can scan the QR codes that you see on the screen, as Dr. Ariel mentioned, to get more information about our programs that we offer, and also to join our Facebook group. We're currently offering a weekly live study group, and we have 2 types of one-to-one sessions. We have many other programs that are launching soon, all designed by Dr. Ariel, and all with the intention passing your board exam. We want everyone to be successful. I want to also talk to you a little bit about a promotional discount that we are offering. But first, just to kind of go through the programs, for the one-to-one sessions, we offer tutor session and readiness test. For the tutor sessions, that is a 1-hour session that's done in a question and answer format, and it's individualized to meet the needs of the student. The amount of questions and topics covered depends on how much discussion and explanation is needed by the student. You can take notes, you can ask your faculty member questions, and topics cover high-yield content for the exams. Again, those are 1 hour in length. We also have one-to-one readiness sessions for both the AANP and ANCC. It involves questions delivered verbally by your faculty member and answered verbally by you. All the questions cover, again, high-yield topics for the exams, things that you have to know before you take your board exam. Your performance is scored in the readiness tests, and recommendations are given based on your results. And you'll get a study plan from your faculty member if you have areas that need improvement. For the readiness test, you should not take it 72 hours before your board exam, just in case you need to reschedule your board exam based on the score that you got from your readiness test. Those readiness tests are 2 hours in duration. And we also have our very, very popular live study group sessions. These are every Tuesday night, and it's offered on a subscription basis. You can sign up any day of the month that you'd like to. And then your subscription renews the next month on the same day that you signed up. In other words, if I sign up today on August 15th, my subscription will renew on September 15th unless I cancel. So for the live study group, you get up to 25 hours of live lecture from Dr. Ariel. You receive the digital flashcards for each session that correspond to the main topic for each lecture. During the sessions, you get the high-yield quiz box questions that are very high-yield for the exams, very important for exam takers. And you get recordings. The live study group is $2.99 per subscription month. You'll get 4 or 5 Tuesdays, up to 25 hours, as I mentioned, depending on how many Tuesdays there are in that particular month that you joined. That live study group is really the very best value that is offered out there right now among all review courses. And we do want to let you know that we're doing a promotion for back to school. So we're going to do 20% off the live study group for all new members and all renewing members. So this promotion, actually, we're going to have a coupon that's going to be available on our website as of August 23rd. So please check the website if you want to get the coupon. But if you're interested in joining now and you'd like to attend next Tuesday's study group, just email me and I will be happy to send you a coupon code that you can use when you sign up or subscribe on the website. My email address is Joanne@Tolentino NP Reviews. So that's Joanne, JOANNE at Tolentino NP Reviews with an S.com. And I'll be happy to answer any questions that you might have and send you a coupon code. Don't forget to check out our Facebook group, our Facebook page. And we also want to mention to you that there's a humanitarian component to Tolentino NP Reviews. We are also connected to a organization that does medical missions in the Philippines called League of Volunteers for Relief Expeditions. You can find a link to that on our website if you're interested. So a portion of all of our proceeds goes to this humanitarian organization. So we just wanted to share that with you. Again, if you have any questions, please feel free to reach out to me, Joanne, JOANNE, at Tolentino NP Reviews with an S.com. Joanne at Tolentino NP Reviews.com. Okay, thank you very much. And I will just turn it back to Dr. Ariel for a closing remark.
Okay. Thank you so much, Joanne, and thank you so much to the learning community. We will be having a series of these webinars to really dig into the knowledge associated with very high yield, very important concepts in primary care, and those concepts that are frequently dealt with in the examination. Very important for being successful in your test, very important in clinical practice. So until that time, thank you so much, everyone. And it's been nice to have you in this webinar, in this learning community. Thank you, and have a good day or have a good night. Bye-bye.